Everyone. Welcome. I would like to welcome. My name is DT Ratna Pradeep. I am a program director of the Master of Public Health program. I would like to welcome everyone to the National Public Health Week at Creighton University. We have been hosting this National Public Health Week beginning for this year, since Monday. We have a speaker almost every day. So today is a Friday. We are very honored to have Dr. Maureen Tierney to speak with us. And her topic today is about how the pandemic uncovered inequalities and opportunities. So this is the very timely, and we appreciate Dr. Tierney, her time, because this is a very busy time, as you're aware, about the COVID-19. So having said that, with this presentation, I would like to, again, thank you for everyone for your interest about the public health program at Creighton University and around our nations. So I would like to have a few words regarding about Dr. Maureen Tierney. And Dr. Maureen Tierney is the chair of the Department of Clinical Research, the assistant dean for the clinical research and public health, and associate professor of the medicine at Creighton University School of Medicine. Dr. Tierney is also a medical director of the clinical research at CHI Health and adjunct associate professor at the College of Public Health, University of Nebraska Medical Center. Dr. Tierney received her medical degree from Cornell Medical College and training in internal medicine and infectious disease at New York Hospital Cornell and Massachusetts General Hospital. Dr. Tierney earned a Master of Science in Health Services Administration, Health Policy from the Harvard and School of Public Health, and then joined the staff at the infectious disease at the Massachusetts General Hospital. Later became the chief of infectious disease at the West Roxbury Harvard Veteran Administration Medical Center. She served as senior medical reviewer for the Food and Drug Administration from 2002 to 2008. After moving to Nebraska, Dr. Tierney joined the Nebraska Department of Health and Human Services Epidemiology Unit as the medical director of the Healthcare Associated Infections and Antimicrobial Resistance Program. From February through May 20, 2020, Dr. Tierney authored and hosts several services to the public health and clinical COVID-19, update the webinar for the Nebraska medical community and labor to decrease COVID-19 transmission in the long-term care. She received the 2020 McKnight Prize, the Healthcare Outbreak Heroes Awarded by the CDC. Dr. Tierney joined the Creighton School of Medicine faculty in July 2020. Dr. Tierney, thank you so much for your time. We appreciate that. As I mentioned, that you're very busy, and welcome to, the floor is yours, please. Thank you.
Well, thank you so much. I am going to share. Is my screen shared already? Or
nope, you want to go ahead. It's ready for you to share.
Okay, great. Well, hello, everyone. I am really thrilled to be here. Talking about public health is something I truly love to do. So I'm just finding my slides. Here we go. And let me go up to the beginning. Always a good place to start. Oops. Here we go. So I want to talk about COVID-19 and the pandemic and how it's been handled from a public health standpoint, but how in particular along the way that we can point out how it sort of uncovered even more specifically some health inequities, but also gave us some better data and opportunities to address them. So one of the first things I want to give you is the lay of the land of public health in the state of Nebraska by talking a little bit about the local health departments. So a couple of times you're going to notice through this is that I say all public health is local. because if you don't understand the local community, then it's hard to address any issues or concerns within those communities. So Nebraska has 19 local health departments, and in most of Nebraska, those incorporate a couple of counties. So Douglas County is where Omaha sits, and all of Omaha is contained within Douglas County. But when you go out west, you'll have 3 or 4 counties comprise a local health department or jurisdiction. And Nebraska is what they call a home rule state, which means a local health department has jurisdiction, which they can accede to the State Department of Health and Human Services. But in general, they get to run the show. In the exception of a true statewide public health emergency, and then the Director of Public Health and the governor have control for directed health measures. And as we'll see from the story, that was a little bit part of the story in what happened in the management of COVID. And this is a picture from a long time ago in the pandemic. So these numbers do not have relation to present day reality, but I just wanted to give you the idea of where the local health department jurisdictions are. So if you look out here, the panhandle of Nebraska has 8, 9 counties in it. Whereas if you move all the way into the southeast, you'll see that Douglas County just is 1 county within a local health department. You know, there are, like any state, there's a reportable disease list. So one of the things that gives public health authority is this public health reportable disease list. And in those reportable disease lists, there's always the capacity to expand in an emergency and make something reportable in an epidemic, or in this case, pandemic. So the reporting of any COVID positive test is mandatory in the state of Nebraska, and it is in all states right now. But that's not something that just happens. It's actually something that needs to be created. And then in addition, the Chief Medical Officer, Director of Public Health, and the governor have the capacity to put in place directed health measures, such as when we went to the capacity or changing when schools were closed and there could be no more than a certain percentage of people within at an in-person event versus an out-person event, et cetera. Those are called directed health measures. They require signature by a governor or the head of the Director of Public Health for a particular state. So I love data, and because data keeps us honest if we use our data correctly, and it really helps us pinpoint the source of inequities or the cause of a problem. And if we do it right, it helps us be able to try and direct resources to try and figure out the problem or to amend it. And so it's really crucial to get your data and to get it right. And so in the management of epidemics or pandemics, data is used to detect and therefore contain, to do community surveillance and look for patterns or disease burden, to direct interventions, to look for patterns or inequities. You know, particularly within public health, the whole area of data informatics has now become increasingly important to deal with large databases. So we can actually look for patterns and inequities in a larger setting. So informatics, I say there is because I think a good part of the future of public health and clearly population health is really high quality informatics. One example of that in Nebraska that was developed before COVID was the antibiotic susceptibility data mart, where all positive cultures for certain kinds of organisms actually must be reported with their antibiotic susceptibilities. It helps Nebraska be one of the better states at actually following patterns of antimicrobial resistance. I'm just going to skip that slide. So when we're trying to detect particular illnesses, one of the first things you need to do is have a case definition. And then you're using, in terms of detection, to try and determine who has the disease, how serious is it, what are the risk factors for that disease, how do you diagnose it? In particular, when you're using and developing testing, what's the sensitivity and specificity of those tests? And then you're going to use the data to direct intervention. So if we can all think back to where we were in February and March, and even April, the concept of the sensitivity and specificity and availability of testing was a big part of the story of COVID. The tests were so limited, that we actually weren't able to utilize them on a wide scale to diagnose it. And we didn't really have an idea of the sensitivity or specificity. Later on, when there was the development of the rapid antigen test, there was the issue of, gee, the PCR, once it got perfected, highly sensitive test if it's performed right. Antigen test, specificity not so great, depending on who's using it and how well they do the test. It can be anywhere from 50 to 80% sensitive, highly specific. So it kind of depends on what you're looking for in a test, whether you want it sensitive or specific. And then what are the containment tools that we need to use? By figuring out the method of transmission and how infectious something are the major things that are going to determine how you're going to contain it. So again, early on, there was this question, is this totally droplet? Is it airborne? Can it be transmitted by surfaces? And it took a really long time to clarify that this is what I would call droplet plus. So it's mostly transmitted by droplets, but it actually can be aerosolized in certain situations and settings, particularly maybe if people are singing or yelling, or a very explosive cough. Some of the particles can actually aerosolize. And so depending on your situation, that's one of the reasons for some of the changing recommendations for masking, for distancing, have changed over time. So, and most recently, there's been some increasing data on, yes, it can be transferred via surface, but that's really a lower likelihood. So we can focus less on that and really focus the most on the reduction in transmission by droplets and sometimes airborne transmission. You know, in outbreak management, I'm just sort of giving some of the basic public health keys is that you look at an epi curve. You decide, is this a facility outbreak versus a community outbreak? What's your control going to be based on? What are the public health laws that help you enact public health protections, but also protect the privacy of individuals? And sometimes there are conflicting issues with that, and there will require legal and moral and public health professionals to determine which is the sort of most significant factor. And usually in that scenario, the protection, what is considered the greater protection of the public health, will be the leading principle. But in public health, in addition to the things that we talked about, in addition to understanding, getting good data, so then you can then make a determination of how to control it, and then utilize those containment, doing public health investigations to see the extent of it, figuring out how to contain it. But then we have to communicate about it. And this is one of the areas where I think some of the greatest lessons can be learned from COVID. And do you need to communicate differently with different folks? You obviously need to make sure that all your communication that goes to the public is available to everyone who's going to reach it. So you are going to use print, you're going to use radio, you're going to use television, you're going to use billboards, but you also have to use community advocates. You have to make sure it's available in multiple languages. You have to make sure helplines are available, that there's mechanisms, information lines, because there are folks who may not have, you know, the majority of, you've got to have good websites, right? That's probably where the majority of people go. But there's a number of people, particularly in more disadvantaged communities, who don't have capacity to utilize websites. And so you must have other mechanisms that actually will provide that communication. So there needs to be communication from federal to state levels, state to local health departments, and then local health departments to their communities and their constituents. I want to quickly, it's really important, and I'm sure hopefully a year from now, the conversation that we'll be having is a more in-depth conversation that's more data-driven on the lessons that we learned from COVID-19. I still think COVID-19 is going to be around in a certain degree. I think we'll be getting booster vaccines. I don't think it's going to be a complete memory, but I think it's going to be extremely important to look back and to say, what did we do right and what did we do wrong? And I'd like to emphasize, I think a lot of things got done right. I think there were tremendous public health. Many of my colleagues have been working 7 days a week since this began and have been dedicated to try and fighting this in the best way possible, frontline healthcare workers. So there's a lot that's gone right, but there are some things that have gone wrong. So we need to learn the lessons of the things that went wrong. And, you know, there were two epidemics in recent history for which we learned some lessons that made us better prepared. So H1N1 was obviously an epidemic in 2009. It hit the Omaha and Nebraska area significantly. And what did we learn for that? Some of the things we learned is when you have limited vaccine, you have to have the discussions ahead of time about how are we going to distribute vaccines when we have a limited amount of it? How are we going to prioritize that? How are we going to figure out the most vulnerable populations that need to be vaccinated first? There was an expansion of something called FluNet influenza testing and reporting. So surveillance testing, where there were surveillance sites all around the state that could tell us what the activity of influenza was. And that's selected for testing of certain variant strains. And that's obviously a big issue right now. What's the story of COVID? It's vaccines and variants, and we'll get to that a little bit later. It inspired pandemic flu preparations to be put in place. And it created a more robust partnerships amongst healthcare facilities, healthcare coalitions, and local health departments. What did we learn from Ebola? The major things we learned from Ebola was that the infection control infrastructure at all levels of healthcare was not what it should be. And it instituted a major CDC effort and funding mechanism to try and improve infection control by creating healthcare-associated infectious disease departments within epidemiology and public health. And that was my job I had before I came to Creighton. For 7 years, I helped lead that effort in Nebraska to try and do that. And that worked well in terms of looking at hospitals, both large and small. But in long-term care, it was a very voluntary process. And that is something that may have come back to bite us a little bit, which we'll talk about in this setting. So emergency preparedness, which is one of the things that both Ebola and H1N1 sort of brought out, is were we on a large scale? Were we really ready? And emergency preparedness needs to be an entity unto itself, but which permeates all areas of public health. So you need to have an incident command structure. You need to have pandemic plans that were developed, coalitions. You need to make sure that you have reserve supply of PPE and ventilators or any other critical mechanisms or supplies that you will need in a certain setting. You need to have staffing for surge capacity. You need to have capacity for high-level care, to transport to high-level care. Eventually, we now have high-level, very sophisticated care for COVID patients all through the state. So all the way out in Scottsbluff, Grand Island, Kearney, North Platte. So there are places that, and even smaller critical access hospitals can manage most patients with severe COVID. But we needed to create early on and then still now. So sometimes you'll need to get a critical access hospital, maybe that's in the panhandle to Scottsbluff or North Platte. So you need to have a very sophisticated transport system to allow that to happen. And one of the reasons I focus on sort of all these issues, because if we improve care for everybody, we're improving care for people in disadvantaged communities. But we also have to make sure that it gets there. And that's going to be some of this additional discussion. But when I talk about were we ready, I think a lot of us know that There wasn't enough reserve of PPE in this country. There wasn't enough testing reagents. There weren't enough ventilators. And there wasn't enough manufacturing capacity within the United States to support the need within the United States. And I think that that's something that all of us became aware of. So if we go back to the beginning, this is the beginning in terms of COVID. I just want to point out two things. It's, there was opportunities missed early on. There was a large New Year's celebration that occurred in Wuhan that if everybody had really understood what was going to happen, might have been closed down, et cetera. Hindsight is always sort of 2020. What was one of the benefits? The genome was published extremely quickly and tests were developed really quickly. But unfortunately, the test kits had an error, for which we lost about 3 weeks in detection. And then we had a limited number of tests. So we actually had to limit the number of tests for the people we thought were at the highest risk of disease. Huge selection bias in diagnosis. So what was happening was it was spreading somewhat silently in a variety of communities before we knew it, because we were only testing certain particular groups. So primarily people with travel history. And so when you don't know that it's there, you can't isolate and contain it. So you're lost without one of your major containment tools. What else hampered our response early on? We didn't have a knowledge of the spectrum of disease. So at first we were focusing on just people with a dry cough, fever and a dry cough, maybe headache. But then we began to understand that you could have gastrointestinal symptoms being a presenting factor. That took probably a month to figure out. We didn't understand that there was pre-symptomatic and asymptomatic spread of disease. We didn't understand fully, as we talked about before, the droplet and potential airborne transmission in certain settings. And then we had the lack of testing supplies, the lack of preparedness in certain settings, and not enough PPE. So the next couple of slides, I'm just going to skip over. I'd like them there for you to go back to, but it's the evidence for the different prevention strategies, such as masks and distancing and mask mandates, in terms of really how well they work. It's just something that I'd like you to have, but there's no question in my mind that all of those things are extremely effective, and that over time we've come to appreciate even more and more how effective masks are, and how the combination of masks as source control for individuals, especially if they're asymptomatic or pre-symptomatic, as well as personal protection, are absolutely key. This slide will give examples of certain successful interventions and certain models that really work to contain. Creighton University actually put in place a particular model that there's a reference to here, and they were able to continue classes in person by putting in an aggressive 6-foot distancing, all masking model, plexiglass areas in contained areas in dining halls, that actually kept them able to stay open. Now I'd like to start the story where we start to look at vulnerable or disadvantaged communities. So the first disadvantage, or I would say vulnerable community, where it became apparent was long-term care. So I have to say one of the hardest months of my life was actually last March, when I was helping to lead the effort to try and decrease the spread in long-term care, and seeing deaths occur on a daily basis, and struggling with colleagues to try and figure this out. There's a group called ICAP at Nebraska Medicine, and you can just Google them, Nebraska ICAP. And it will come up. In this group, which has grown, has done enormous work at figuring out how to control disease within long-term care. We had to create cohorting systems within long-term care. So there were COVID units and non-COVID units, quarantine units for new admissions, But even at the very beginning of that month, we didn't really understand how the masking of all healthcare workers could significantly decrease transmission. And so there was a lot that we learned in terms of COVID and long-term care. But this population being so vulnerable, obviously, if we look at acquisition of disease and hospitalization and mortality, all of those go up really with age from age 30 on up. You see actually an increase. So with each decade, you increase severity of disease, hospitalization, and death. But it really starts to go up exponentially over 70. So the population in long-term care, there was a lot of loss and a lot of death in that setting. And then the population that became the next sort of concentration of disease in our state, which I think took people by surprise. In retrospect, it shouldn't have, but it did, was the community of individuals working in meatpacking and in the communities around them. And so obviously in meatpacking, you've got folks working in close, stationed to each other. There is the conditions within there are actually, conditions within the air that make it easier for transmission to occur. And then at lunchtime, people would be, a lot of the lunchrooms would be very crowded, and people are, talking close together. And, the communities of folks who worked in meatpacking, for which a lot of the Hispanic community, or a lot of the workers were from the Hispanic community, and then in some areas from the Karen speaking community or the Burmese refugees community. And these folks would often live in multifamily, they'd live with extended family. And so they would go from a work scenario, which was highly densely populated, to a home scenario that was highly densely populated. And so it's not surprising that once you started to have infections in meatpacking, that it was going to spread in a very aggressive way. And as a matter of fact, so one of the first major outbreaks in Nebraska was actually in Hall County, which is where Grand Island is. And so St. Francis Hospital in Grand Island probably became the first hospital to treat the largest number of patients, and got actually very expert at it early on. But one of the reasons these are connected, so this is an area where individuals who have to work full-time in what's considered an essential workforce and are working long hours become exposed at a greater rate. And so there needed to be a tremendous amount of focus on how can we improve the situation in meatpacking. And so there were teams that went out from ICAP and DHHS that determined, how do we improve the airflow? How do we create physical barriers? How do we make sure everybody masks? How do we make sure that anybody who's sick gets paid time off and protected for as long as they're sick in a period of time? How do we improve environmental cleaning, create social distancing? And so there was an aggressive effort made, and some companies were better at doing that more quickly than others, but eventually all got on board that this was absolutely a key way to protect their healthcare workers, but also to protect the community. Because when you started to see increased incidence in meatpacking, then actually that spilled over and seeing increased incidence in long-term care. Because there might be folks in the family who worked in meatpacking who came home, and then other folks in the family who worked in long-term care. So when you increase your rates in a community, you're going to increase your rates in long-term care. Okay, so this is when, again, I say all public health is local, is that, so the places, so we started to see it in long-term care, then we started to see it in meatpacking. And then the major outbreaks in long-term care seem to be in the long-term care facilities that surrounded areas where there was more meatpacking plants. So again, knowing your communities is absolutely crucial. And then we got to the point, we all locked down. We started to learn more about testing and have more tests available. We started to learn a little bit more about transmission. everybody hunkered down. And then we sort of got to June, and the CDC had recommended a sort of phased opening approach based on case fatality rates, or really not case fatality rates, but positivity rates in communities. But unfortunately, and this is my opinion, public health wise, that didn't happen. And I think that had we taken that more phased approach, the major waves that we had in the Southeast, and basically over the summer, which then extended to Arizona and California, might not have happened. And so, what are some of the things that caused that? We didn't follow those messages. There was a lack of consistent messaging around the country, so that every state and local jurisdiction needed to create some, unique messages for their community. And you always want to have a certain amount of, as we said before, all public health is local, but sometimes public health needs both the state and federal back and support and consistency. And I would say a pandemic is one of those places. So it actually gives that backing and support to local efforts. Masking became politicized. I don't think I need to, support that. I think that's a fairly common understanding at this point in time. And how did that happen? There's a whole variety of reasons for that. And I would refer people to a piece in the New England Journal called A Tribal Truce, which was in the fall of last year. That's an absolutely wonderful piece. That's very, it doesn't take sides in this issue, but gives a sort of a discussion of the evolution. I would recommend everybody in public health read this piece. It helped me understand sort of this evolution of almost a badge of honor to be non-science. And I found it very helpful. And I think there were missteps in messaging along the way, which is very easy in a setting where things are changing. And I think that message needed to be made even more thoroughly, is to prepare people for the expectation that the message will change as we get more and more information. But I think that's also a cautionary tale in the sense that you have to be careful what you promise early on, because people remember, or is it what you say first and what you say last? They don't remember a lot of the middle, right? And so, in the discussion in the beginning, which is, gee, you don't need to wear masks, that message stayed with a lot of people. Now, I actually happen to be, actually, maybe you can't see me on screen, but this is my Tony Fauci bobblehead. Okay, I'm a big proponent. I actually know Dr. Fauci. He trained at the same place I did. And, and even though I think he's been a phenomenal messenger throughout this, when, he made the recommendation, well, gee, we don't think folks need masks, we can all criticize everybody, but could he have said, as of this point in time, we don't think people need masks because we don't understand totally the transmission. Leave the door open kind of a little bit, because as I say, people have taken that statement inappropriately, I think, and used it as criticism. Again, part of that reasoning was because we were low on masks and healthcare workers needed those masks. But I think you always have to be, when you're doing public health messaging, you have to be careful what you promise. Never say, in my mind, 0 or 100%. Never say anything is 100% effective. Never say you have 0% deaths or 0% side effects, because you can never keep those promises. And just be as honest as you can. Now, one thing I just want to quickly show you, when you look back at the data in May, never, and this is something that people entering public health now we're going to be able, DT and I, to back and say, now in our day, or in those days, when we had to do all this data by hand, or we had to do, but never has there been such a need for so much data to be acquired so quickly. It's really quite extraordinary. Influenza data, which we thought we were pretty sharp and good on, was reported on a weekly basis. And we needed to move to be able to get case numbers, hospitalization rates, death rates, testing done, within 24 hours and report them on a daily basis. Never been done before. So, but doing it with the same workforce that had been doing influenza on a weekly basis. So one thing that happened is the workforce exploded, which is why everybody on this call is going to have a job, because there's just such a need. But this is the sort of way we were when we were back in May. The data was just very, it was good data. I'm not saying it wasn't good data, but it wasn't really presented in a very sophisticated way. And now we move to where we are now. And I was going to try and open my screen up to the DHHS database right now to get the more updated numbers. But I want to show this really more as an example. But I would urge you to go to Nebraska DHHS COVID dashboard. And there are two dashboards on there right now. There's a dashboard that looks at, and this is an example, actually, this is from December, but what it looks like right now is it tells you the total number of cases diagnosed, the total hospitalizations, the cases that are diagnosed, what are, this is, total deaths. If you go to additional cases, it will then look at where your cases are around the state. It will give you the idea of hospital and ICU bed availability. So it gives information by cases by age, cases, hospitalization by age, deaths by age, cases, hospitalizations, and deaths by race. Oops, I skipped a slide or two, hold on. And then by ethnicity. One thing that they don't do, however, so I did, and I took the most recent data last night. So this was more, this is something in terms of the presentation of data. So this data is all useful and it's all valuable. But what a lot of people want to know is what's the percentage, not just so you look at that and it gives you a perspective. Okay, deaths go up by age, hospitalization goes up by age. It doesn't tell you percentages of different populations in terms of their deaths and hospitalizations. So this actually goes over hospitalization rates and deaths. And so if you look at your hospitalization and your deaths, and you look at when you get up to your sort of 11% 85 and over in terms of deaths, 16% hospitalization rates. So the numbers go up extraordinarily by age. But if you look at your next slide, I wanted to make sure that we looked at deaths and hospitalizations by race and ethnicity. And so if you look back at those numbers, and if you look at the dashboard, it's going to give a slide that talks about it by race, and then a second slide that divides the white population by white, Hispanic, and white non-Hispanic. So I decided to take information looking at the census data for race and ethnicity, and then look at the number of cases, look at, sorry, my emails keep popping up there, the number of cases within those groups, the case percentage in that population, deaths per positive case within that population, and hospitalization. So if you look at the white non-Hispanic population, 2.9% actually, and this is present day data, have been, whoops, actually that might be the old data, never mind, let's move. Okay, good. So this is as of last evening, all right? So as of last evening, the 5.9% of the white non-Hispanic population has a positive test reported. Obviously, it's probably 2 to 3 or maybe 4 times that. But that's it. Of the hospitalizations, 1.3% of white non-Hispanics who were diagnosed actually were hospitalized. I mean, died, and 4.25% were hospitalized. Now let's look at white non-Hispanics. This is one of the numbers that pops out at me in this chart. Of this 17,456 positive tests in this population, 11.8% of the population of white non-Hispanics in the state of Nebraska, which is over 200,000 people, actually had a positive test. But interestingly, the rate of hospitalization is approximately the same. So of the people who were tested positive, the hospitalization rate is fairly the same as for the white non-Hispanic population, but the death rate's actually lower. So actually, probably the major driver of that is the fact that this was happening in younger people. So there were more older individuals, probably who are nursing home residents in your white non-Hispanic population testing positive. But you had a younger population, more of a working age population in the white Hispanic population. Another area, if you look in your African-American population, there's about 90 to 95,000 African-Americans in the state of Nebraska. It's only about 5% of the population in the state, but about 11% of the population in the Omaha metro. But the rate of positive cases is about the same in the white population. And the death rate is actually about the same or slightly better, but the hospitalization rate is higher. So what could be the reasons for that? Could it be that that there were more comorbidities in that population because their primary health care wasn't as adequate? But it's encouraging to see that the death rate is fairly similar. And one of the things I want to point out when I say all public health is local, and DT, I'm going to get there, I won't be too much longer, is the fact if you looked at similar data in New York City, which is the city of my birth, zip code determined mortality markedly. And that's because if you're in the Bronx, for example, as opposed to the center of Manhattan, and you were hospitalized with COVID, your case fatality rate was increased by factors, sort of exponentially, because the quality of care provided in those communities. So in places with larger centers of minority or disadvantaged communities, the death rates were higher. In Omaha, everybody goes to 3 or 4 major hospitals, right? No matter kind of where you live, at least in the metro areas, everybody's going to UNMC, CHI hospitals, Methodist, or and St. E's and Bryan and Lincoln. So everyone's getting good care. So actually, one thing I'm kind of proud of, we need to work on this number. It means we need to improve primary care, but in certain communities. But once people were hospitalized, their care was relatively equivalent. CDC, which I've linked, has a really wonderful piece on racial disparities. It actually has multiple MMWRs on this issue, but it was one of the first major publications to note that differentiation. I want to talk, there's information here about vaccine safety. I would say this is one of the areas in terms of messaging where you don't say 100% and you don't say 0. Okay, so you don't say that, people have been talking about it's 100% against hospitalization and death. Well, when you move to populations of millions of people, you are going to have small percentage of people who have severe reactions or who actually have vaccine breakthrough. So those things are going to happen, but the numbers are still tremendously small. These are better vaccines than we've had for most illnesses, clearly markedly better than for influenza. But if you start to look at vaccination by race and ethnicity, again, this is an important thing. So these numbers are incomplete. There's not a full data on race and ethnicity, but as best I can tell, that white non-Hispanics are getting vaccinated at a higher rate than white Hispanics or African Americans. And so things have been done to try and improve that aggressively. And those numbers, if you start to look at, those were from a week ago, and they are already improved because the efforts to ensure equitable vaccination, such as making sure there's location of clinics, not just in West Omaha, but there's more in North Omaha. There's now going to be a drive-through in the MCC Fort North campus, at certain churches, at the FQHCs, transportation to other sites, timing the clinics for people who actually work from 8 to 5. Making sure there's information and interpreters on site, and making sure there's registry options for those who don't have computers. And then there's this is my last slide, DT, the vaccine hesitancy issue. there has been vaccine hesitancy in every population. You know, there's vaccine hesitancy in certain disadvantaged communities. There's some in middle-aged white men. And so, you know, you want, and then women of childbearing years. So you need to focus messaging. But town halls have been done in North Omaha, in South Omaha, in the Karen speaking community. Those are the ones I've done the most of. They've been so gratifying and useful and helpful. Get community health advocates involved, trusted community leaders, and physicians and nurses from minority communities. I would say there's probably been over 20 town halls led, and CEO Smith from DHHS, who is a woman of color herself, has actually led many of those. So I'm going to close there. I always speak a little bit longer than I'm supposed to, but it wasn't too bad, DT, only 5 minutes.
Well, we appreciate Dr. Tierney. Thank you so much. Very helpful. So I'm going to open, some of the question, if the audience have some question, please send it to the chat line, and Terry and I will, try to get this to Dr. Tierney.
DT, I just want to say one thing.
Please.
I want to update those vaccine numbers. And so I'm sharing this with this group as a group of trusted individuals. Okay. And learning individuals, but these are really not for press release or public consumption in the setting that there's a lot of unknown folks. So there are times when people are vaccinated, et cetera, where the unknown box or the data weren't collected. So these are trends. They're not absolute numbers, but I felt it was important for the educational purposes to present those trends. I'll update them. And we'll be able, when we put this up for public consumption, that I have the most accurate numbers. But that'll probably take till Monday, if that's okay.
Sure. Thank you so much. So while I was waiting for, from the audience to maybe, share some of the question, I do have some, I do have two questions, and one of them, and, that you've been presenting regardless about the, regarding about the response efforts. It's with the minority, that one question. And the second question regarding about the new UK variants, So having said that, the first question I have, how does messaging change or need to change to address the concerns specific to the different minorities?
I think one of the most important things is to have an understanding about what messaging particular communities want to hear or need to hear. And that's why doing the town halls in particular communities gives us an understanding and an opportunity to get the questions. So for example, I've done two with the Karen community. And, and so we've gotten questions from that community that might have been particular culturally questions related to certain cultural issues that maybe wouldn't have been addressed in a more general public messaging statement. So I think it's really important to go to particular communities and understand what questions there are, what concerns there are, and then try and message them directly. I think it's absolutely crucial to make sure that messaging is available in all the languages that are spoken in a particular area in that community, so that they don't, that those translations are available right up front, not weeks later, which is often.
Thank you. Thank you. So while we're waiting for a few more questions here, the next question I have, as you're aware, that regarding about, from the media, that the new UK variants is beginning to be detected even more in different communities. So how, in terms of efforts of, try to control the current one and then the new one, how is that change you as the front line of, try to get the vaccination to the, community? And here, this is, what the message that you would share, especially, folk who haven't received the vaccine yet?
One of the messages I always like to share is that to try and contain a virus, to try and reduce this pandemic, we actually, if the way you can contain a virus and end a pandemic is by reducing the number of hosts. So a virus needs a host. It needs to infect someone to multiply and then infect somebody else. Viruses don't, particularly this virus, doesn't survive long outside of a human host. And so the major ways that we can prevent this virus from taking hold so it can multiply and therefore infect others is number one, vaccination. That is by far and away the most effective way to try and control this vaccine. The other methods are still tremendously useful and should still be used until we have herd immunity and control of the variants, masking, social distancing, avoiding crowds. But I think to me, the biggest concern is that right now, the UK variant and the California variant, and to a good extent, the South African variant, are all susceptible to the immunity developed by the vaccines. There's a variant P1 that's in Brazil that may not be as started in Brazil, but may not be as, that virus may not be as susceptible. So the key is we need to get vaccination as widespread as possible before we have variants that won't respond to the vaccine. So this is really a race against time. It is important to get the vaccine and to get it as soon as possible.
Yes. Thank you. I do have a few questions posted here that there was one of the question I recently, from the audience, I recently heard an NPR broadcast about concerns in the Canadian Muslim community about being vaccinated during the Ramadan. Has that been a concern here?
I have not heard that as a concern. But if it is a concern, I think it would be very important for us to address that and include some of our public health and physicians who are of the Muslim faith to weigh in on that. Dr. Salman Ashraf is one of the leaders in the COVID response in the state. I think he can help address that if that becomes a concern.
Yes, thank you. Next question is, could you please comment on the value of the proposed giant University of Nebraska Medical Center project related to the future pandemic response?
That's a tough question to put to me because I don't know the specifics of that whole proposal. The whole details of the proposal, I don't believe have been made public. Maybe I'm wrong. I've been focusing so much on just kind of COVID response itself. But I certainly think the ability to train individuals in pandemic response, in infection prevention techniques, a lot of that's already being done. Part of that from grants from the state as well as federal grants at NETEC and ICAP. So I think it never hurts to have more people have greater knowledge and training in that area.
Okay. Thank you. Thank you. So we have about 6 minutes left. So I like to, value, our speaker time and also the audience time. So the question is, it being posted. I'm going to read the next one here. That when the audience said, I have heard the term targeting being used when talking about vaccinations, at the POD and the clinics. Is there a better way to verbalize this message so that other population do not feel marginalized? I have tried to avoid that wordings as much as possible.
I'm not sure I understand. So using the word targeting is something that should be avoided.
Right. So it should be avoided. Are there any, because sometimes, when we're looking at the, we try to vaccinate because they are the high risk group. There are group that we need to, as you probably are not targeting. Well, this is the thing that, we all, because we are focused on, try to address a specific concern. As you're aware that, right now, the group, the COVID exposure right now moving to the younger population, right? So we cannot move our focus, move our efforts in there. So sometimes we're using the word targeting. So is any, we try to mark, so people won't feel that we are, targeted to specific population. Yeah.
I definitely appreciate that question, and words mean a lot, and how we use them. So, you know, and maybe that's one of the reasons I like data so much, is that you know, I think it's really important to try and why I think it's so wonderful that we now have all this data, is to not use data and not use the word target, but to say, okay, looking at what data we have, the areas where we're lacking in getting people vaccinated, or an area where we see people have particular greater risk of harm, that in a way to use data to say, these are areas where people are, as I say, are either at greater risk or are not getting the services they need. So let's try and fix those issues, as opposed to say we're going to target a population.
Sure.
That's how I would like to approach them.
You bet. There is a share on the chat. You know, there's more information that available to, you know, you can find on the Department of Health and Human Services Nebraska dashboard. That, you know, the link is in there. You know, they're about the COVID-19. This data dashboard is been updated, right? This is it's not the real-time data, right? Am I correct?
Right. Yeah. In my slides, because the dashboard sort of changes sort of very dramatically. So what is in my slides is not the most up-to-date dashboard, because it changes every day. So even if I put, you know, by the time these slides get posted, it's already out of date. I wanted to put those in here for an example of what it can show you, but I highly recommend going into it and taking a look around it. You'll find areas in it that aren't as up to date as others, because I think they have a limited number of folks, and right now many of those folks have switched to vaccination, you know, so that data dashboard I think is more up to date right now. The Douglas County has you know, because it's populous enough, Douglas and Lincoln have their own data dashboards that are up there, and they're slightly different. And Douglas County does a great job at its data collection. It's probably got some of the best epidemiologists around in figuring that out. So if you have particular questions about Douglas County and Omaha, I would also recommend going to the Douglas County COVID dashboard.
Thank you. We have about 2 minutes left, and I would like to, you know, maybe one more question would be, you know, I can absolutely ask Dr. Tierney to answer that. Maybe in the meantime, would you comment on, you know, there is the news last night, and also you forward that to me about the Creighton University and CHI are, you know, beginning to do some of the testing with the new variants on this. Could you comment on this? How is this testing, you know, that the lab that we are doing at the Creighton and CHI will help, especially with the community that has, you know, disadvantage on that? Would you comment on that, please?
Well, I think that so right now there's 3 sites that have the capacity to do the sequencing of a positive test. So the PCR test actually tells you whether, you know, your PCR is positive or negative. Do you have COVID or not? Yeah. With pretty good assurity. Those samples, those specimens can then need to be sent to a place that can actually do this genomic sequencing, which is actually expensive and hard to do. It's not, no one pays for this, I mean, as of an individual. So if you're an individual that is COVID positive and your test goes for sequencing, that cost is never going to get passed on to an individual. So, you know, basically all positive tests. So the way that we're doing it at CHI and Creighton, Nebraska Public Health Lab gets specimens from around the state that people are highly suspicious might be variants. It's a reinfection, it's someone who traveled, someone who's particularly ill. So there's a particular suspicion. And that's useful, but it's somewhat of a skewed, it's going to be skewed towards being positive for a variant. One of the other things, one of the reasons the state wanted to work with CHI and Creighton is that any positive test that comes out of the CHI lab for the metro, okay, so that's going to include people who come from university campus, which has a higher percentage of folks from disadvantaged communities, Creighton, Bergen, Emmanuel, Lakeside. So it's actually a variety of different zip codes and areas. Any positive test from the CHI lab is being sequenced at Creighton.
Okay.
So it'll give us a better perspective of the circulating variants in all parts of the community, not just certain.
Well, thank you so much, Dr. Tierney. And we are at the National Public Health Work Team that at Creighton University and the audience. We thank you for your time. I just want to say one thing that tomorrow we have one more session that's celebrating the National Public Health Week. And that session, it will be the virtual yoga with the certified instructor, Lindsay Decker, that on Saturday at 12 o'clock to 1 o'clock. And please join us if you have time. It will be a good, activity. So in that mean, we are wrapping up with the time. And thank you for everyone to participating with the National Public Health Week at Creighton University, and have a good afternoon. Thank you so much. Thank you.